Hello everyone. There's been some concerns regarding the use of laparoscopy during the COVID-19 pandemic, and there are some guidelines currently out, in fact, indicating that perhaps we should not use laparoscopy as the first choice in procedures such as cholecystectomy or appendicectomy. Although this is debatable, however, the fact remains that an open appendicectomy is rarely done nowadays, and particularly our younger trainees might lack experience in performing such an operation. So that's the reason for this brief online tutorial, so that we can go through some of the technical aspects of the procedure, but also maybe highlighting some of the pitfalls. Most of the things that I'm saying here is not based on any publications, but purely based on what I have seen and what I have done, and it's my personal experience. So we have essentially two aims in this tutorial. One is to describe the procedure, and secondly, maybe highlighting some of the pitfalls. So first, the procedure. The paramount is the access, gaining access to this appendix. And nowadays, we have access, in fact, to CT scan preoperatively. And for me, the planning of the procedure starts off with reviewing of the CT scan. And the kind of things that you would want to note, provided that the decision is to do an appendicectomy, are number one, where is the base and the tip of this appendix? Is it retrocecal? Is it pelvic? Is it non-descended cecum or malrotated cecum? The second point to consider on the CT scan is to look for the degree of contamination. Is there free gas, lots of contamination in the abdomen, or not, particularly, for example, four-quadrant contamination. And that will obviously be evident on your clinical examination, with patient being tender all over, with rigidity to percussion and coughing. And lastly, the CT scan will be reviewed, particularly looking for any masses around the cecum, because that will then obviously raise the possibility of this being a tumor. So assuming that this is a relatively simple appendix and it does not require a midline laparotomy, and for me the indications for that, as I said, one is a gross contamination of the abdomen requiring access to 4 quadrants of the abdomen, or a large mass that perhaps necessitates the removal of the cecum, and a kind of a limited right hemicolectomy. In those situations, I would perhaps consider a midline laparotomy. Otherwise, you will be more inclined to go for an incision in the right iliac fossa. Now, there are a number of descriptions here, but one of the things that is very important once the patient is asleep and under muscle relaxation is to actually have a feel of the belly yourself before scrubbing the abdomen, prepping the abdomen. And in particular, you would want to locate any fullness or mass, and that's essentially where roughly you're going to put your incision. If there is a mass or a fullness, you would want to go just above that incision, because that gives you access to the right colon in case you need to mobilize the right colon. So roughly over the mass and just above it. And then there's the choices. Essentially, the choices are you either go completely transverse or oblique. People talk about McBurney's point. McBurney's point, a third of the way from the superior iliac spine to the umbilicus. A lot of our patients are obese. Umbilicus is not a very reliable landmark. So essentially feeling the abdomen, and also preoperatively on the CT scan in relation to the bony landmarks, getting a feel for where you might want to put your incision preoperatively on the CT scan. So the CT scan is critical when it comes to planning the procedure if you have access to it. So the incision, should you say decide to go for an oblique one, people talk about McBurney's incision, which is essentially if you draw a line between the anterior superior iliac spine and join it to the umbilicus in a normal weight patient, a third of the way, then you draw another line perpendicular to that. That's the line of your incision. It's a line perpendicular to the line that connects to the superior iliac spine to the umbilicus. And that line should be, the incision line should be a third above your and a 2/3 below the line between the superior iliac spine and the umbilicus, and it's about 6 centimeters in length, roughly. The other alternative is just to go transverse, a lance incision. Either way, a sharp scalpel, that's all you need, minimizing the use of diathermy. The critical thing about the use of a scalpel is minimizing the number of strokes that you do. That minimizes bleeding, but also when you're going for the second stroke, making sure that you go to the very depth and the apex of your first stroke rather than creating multiple levels and planes of incision. And that makes it very ragged, more prone to infection and non-healing. So you make your incision down through the scarpus fascia, skin, fat, scarpus fascia, more fat, and then you go to the anterior, to the external oblique aponeurosis. The external oblique aponeurosis is just split and opened along its fibers, and then you go down to the transversus abdominis and internal oblique. The internal oblique and transversus abdominis are then split slightly laterally with the aid of clips, and then 2 fingers on either side, and you just gently you pull them apart. The gentler you do this, the better the splitting, the so-called muscle splitting technique, and you basically keep doing it till they don't come apart any further. You might get a little bit of bleeding. You can very quickly stop that either with diathermy or just with a bit of pressure. It usually stops from the muscle. If the patient is obviously obese, and a lot of our patients in Scotland are, 60% of the population are either overweight or obese, then you might have to extend this skin incision. But very often what you really require is perhaps good retraction, so good use of your assistant and good retraction, but also you also got the option of actually splitting and opening the rectus sheath and the rectus muscle anteriorly. Maybe a couple of centimeters sometimes is enough rather than splitting the whole of the rectus, and that gives you extra exposure. But you shouldn't hesitate in actually opening the muscle and cutting the muscle, both the rectus muscle on the right side, but also the muscles laterally. And that really just gives you a fairly good exposure. This also becomes a bit more relevant in very muscular patients, and very often a lot of obese patients are also muscular because they carry excess weight, and hence the muscles become hypertrophied. So a combination of muscularity as well as obesity usually necessitates larger incision. So it's not cosmetic surgery. You don't want to go overboard, but don't struggle with a small incision. And very often, whenever I used to get called in at the time of we used to do open appendicectomies, was because the junior trainee couldn't get access or find the appendix, was just simply to extend the incision. And very often the appendix falls into your hand. You do have, obviously, at any point, the option of abandoning that incision and going for midline. And also, you also have the choice of, especially in the case of, say, an oblique incision, McBurney's incision, to extend the incision up the way towards the right upper quadrant, and also extending it transversely up to the midline or even beyond. So there is no hesitation in extending the wound if required, but it's better to do it in stage-wise fashion. Don't struggle, and the first thing you do is you make good use of your assistant, and you make a good use of